Hello, and thank you for attending our Closing the Care Gap and Simplifying DR Screening. I'm Eric Haffney. I'm the Chief Commercial Officer for Remidio Innovation Solutions based here in Richmond, Virginia. We're an ophthalmic device and software manufacturer that's based here in Richmond and in Bangalore, India. I'll be hosting today's webinar where we will cover several issues, concerns, and processes for establishing, maintaining, and growing a successful diabetic retinopathy screening program. Today, you'll hear from real-world experience from our panel of experts on how to successfully screen for diabetic retinopathy and how this can benefit your patients and your clinic. We have four wonderful panelists with us today that will share their unique experience and knowledge about the diabetic retinopathy screening process. First, we have Dr. Divya Rao, our medical director here at Remidio. We have Dr. Arjun Deragangi from the University of Virginia. We have Denise Fisher that's joining us from Prisma Health, and Louis Morrow, who is the Vice President of Sales at Intelligent Retinal Imaging Systems, or IRIS as we call it. But first, we're going to start off with Dr. Rao, and her presentation will be discussing diabetic retinopathy and its prevalence here in the US. Dr. Rao completed her ophthalmology fellowship at LV Prasad, which is one of the top ophthalmic teaching institutes in the world. She is currently the medical director here at Remidio Inc., where she oversees the development and clinical research of Remidio devices and artificial intelligence. But before we step into her presentation, we have a poll question for our audience. Please select the answer within the next 30 seconds for the poll question. We should be getting those results up here. All right, so this is a perfect lead-in, I think, this question into Dr. Rao's presentation. Dr. Rao, please share more about diabetic retinopathy.
Sure. Thank you so much, Eric, for the kind introduction. I'll be covering the answer to this poll question in my talk. So let's dive right in. Next, please. So what is diabetic retinopathy? Diabetic retinopathy is one of the complications of diabetes. It damages the blood vessels of the back of the eye called the retina. Here you can see an image of the normal retina with normal blood vessels. And in the early stages of diabetic retinopathy, you will see changes such as tiny bulges from the walls of smaller blood vessels, yellow lipid deposits, and small bleeds into the retina. And diabetic retinopathy can progress to this more advanced stage known as proliferative diabetic retinopathy. And in this stage, the damaged blood vessels close off, causing the growth of new and abnormal blood vessels in the retina. And these new blood vessels are fragile and can rupture and bleed into the eye. Eventually, a scar tissue can form and cause the retina to actually detach from the back of your eye. Unlike most other conditions, in the early stages, one may not notice any symptoms at all or any change in one's eyesight. But it is at this early stage that preventative measures need to be taken. Next slide, please. So what happens if diabetic retinopathy is undetected and not managed appropriately? It has adverse effects on the patients, the providers, the payers, and the health system in general. For the patient, it means permanent vision loss, loss of productivity, and dependency on the family. For the provider, the complexity of care that needs to be administered increases as the stage of disease advances, from laser photocoagulation to intravitreal anti-VEGF injections to even surgical techniques such as vitrectomy. And for the payer, it means that there is tremendous increase in healthcare costs as the disease advances. And the CDC has determined that diabetes-related blindness costs upward of $500 million annually. Next slide, please. So how big is this problem of how big is this problem? So globally, there are over 500 million people with diabetes, and in the US alone, there are over 34 million people. That is over 11% of the population. And this is projected to increase to 63 million by 2045. What is alarming is that 1 in 3 people with diabetes have some form of diabetic retinopathy, and 1 in 10 have sight-threatening disease. This makes diabetic retinopathy the leading cause of blindness in the working adults in America, and not just those with diabetes. Next slide, please. What compounds the high burden of disease is that despite recommendations by the American Diabetes Association and the American Academy of Ophthalmology for an annual diabetic exam, there is poor compliance. And historically, on an average, not more than 50% of those diagnosed with diabetes get their eyes screened. And in rural communities, this can be far lower. This means that close to 50% of diabetics are actually walking around undiagnosed. And while for this, there is a simple solution to screen the disease early through retinal photography. And the good news is that blindness is almost completely preventable by early detection and treatment. Next slide, please. So what are the key challenges for screening? So from patient perspective, as we discussed, there's lack of awareness as the patient has no eye symptoms in early stages, and the traditional screening process is inconvenient. The primary point of contact for a diabetic is his physician who manages his diabetes. But at the end of the clinic, if he is asked to visit an eye care professional on another day at another location with long wait times to get his eyes evaluated, this is just cumbersome, and like any of us would tend to skip it. He's actually trying to seek different healthcare access points to complete his diabetes care. And from eye care professional perspective, we all know that there's a global shortage of expertise, and this is really no different in the developed world like in the US. And the exponential rise only worsens this problem and increases the burden on an eye care professional. So this really begs the question, how do we really reach this underserved and high-risk diabetic population with preventative measures? The most optimum way is to proactively go where the diabetic patient is instead of having them to come to eye care professionals. So this is decentralizing screening closer to patients, and this could be anywhere in primary care clinics, labs, pharmacies, or even home. And to be able to provide this kind of a mobile screening solution outside of an eye clinic, the technology really needs to fit the bill. A simple to use portable and affordable camera system that is able to capture images, good quality images that can be read by a reading center or an eye care professional through teleophthalmology is one of the solutions. And this solution can actually improve patient outcomes, reduce healthcare costs, and also be economically sustainable for the physician. And we'll hear more about this in the next few talks. Thank you so much for your patient listening.
Thank you, Dr. Rao. Really appreciate it. And I think the takeaway here is early detection and decentralized screening are critical if we want to change the trajectory of this growing disease. And I think that really, brings us to this, our next presenter. The concept is perfect to introduce our next presentation of starting a DR screening program by Dr. Deragagi. Dr. Deragagi is the assistant professor of ophthalmology at the University of Virginia, Department of Ophthalmology, and he's also director of the UVA DRS network for rural and underserved sites within Virginia. He has had an ongoing passion for public health and the application of telemedicine technology to prevent blindness. He has multiple collaborations going on right now with the UVA Department of Telehealth. So Dr. Garaganki, what do we face if we want to set up a DR screening program?
Thanks, Eric. That's a good introduction. Hopefully everybody can hear me. Thanks everybody for joining us today. Again, I'm Arjun Dragangi. I'm I'm an assistant professor of ophthalmology here at UVA. And then also I have a background in international public health, and I'm lucky and fortunate to be able to apply that in the States and in vision public health through this DRS network and some other projects. So what I'm going to talk about today is really sort of getting into a little bit more of the nuts and bolts of designing and applying diabetic retinopathy screening program in a local clinic. So I do have a financial disclosure with an early stage startup that I'm involved with. That's not directly related to this talk. So at UVA, we have a network now that's long established in Virginia in rural and underserved clinics, primary care clinics that is affiliated with our department through a telemedicine program using a network of various different cameras to screen for diabetic retinopathy, which Dr. Rao mentioned very eloquently. We have some common program goals, which are to save patients with diabetes from developing preventable blindness through this early detection and treatment of diabetic retinopathy. None of us here, I'm a glaucoma specialist actually, but some of my colleagues who are retina specialists, we would love to actually have patients present before they develop, these irreversible blinding conditions like neovascular glaucoma and fractional retinal detachment. We really want to catch the patients before they get to that stage. And as Dr. Rao mentioned, many of the patients may be walking around completely asymptomatic, not complaining of blurry vision, any other issue with the eyes, and then have this potentially blinding complication of diabetes, one of the many complications of diabetes, as everyone here knows. We have a goal of increasing the number of Virginia's adult diabetics who do get this annual screening, either for in-person eye exams or through screening photography through telemedicine setup. And we really focus our efforts in medically underserved communities in the Commonwealth. We have placed and worked with sites to place a network of cameras in different sites. We've been working on this since 2014, since before I was involved. I rebooted the program a couple of years ago to be a more decentralized model, and now we've gone up to, at this point, 29 sites, so non-UVA FQHCs, free clinics, and then primary care practices of a variety of different types, as well as one UVA primary care clinic site. And we have a number of different state and national funding sources, which has made this possible. Next slide. So this is always one of these slides that's always obsolete because we keep growing, but we have at this point 29 sites throughout the Commonwealth. Just shows a little bit of where we're based, and then the actual program is based in Charlottesville, which is sort of in central northern Virginia, central Virginia. Next slide, please. This is a little bit of a busy slide. So I have a background in public health, and we've been fortunate to be able to collaborate with the UVA School of Public Health to really make sure that we're in the correct areas. And that was one of our first concerns, was we want to make sure that we're actually tackling screening in the sort of low-hanging fruit, the places where patients are really most likely to develop diabetes and develop severe outcomes from the diabetes. And so we've looked at a number of different risk factors in the state for this, including, so FEI is, which is, so you see the red counties. This is a county map of Virginia and some of the outlying regions. And so the red outline is called FEI, or Food Environment Index. These are food deserts, places where it's tough to get food. If you look at the gray scale within the county, these are the number of diabetics within the county, which is important for us from a programmatic perspective to make sure that the clinics are capable of screening an adequate number of patients. And then uninsured patients. And so the patients with the red are really some of the patients with sort of the triple threat of lots of patients with lots of diabetics, high food insecurity, as well as uninsured. And then one of the things in this map is that we've looked into things like diabetic travel, basically travel distance for patients. How far would they have to go if they were to get eye care, particularly retina care? And for some of the places, like in the southwestern region of the state, in the Appalachian region, patients actually have to drive 5 hours or more to get eye care if they were to actually need to have, for example, retinal treatments. So it made sense for us to try to bridge some of these disparities and these barriers to care with extending screening far further than we could actually go as eye care people, professors. Next slide, please. So this is just giving an idea when I say that, travel distance to retina specialists. And so this is where the retina specialists are within our state. And obviously there's a lot of clustering in Northern Virginia. And if you look with the 10 or 20 mile radius, so there's a number of studies that have shown that as you get even beyond 10 miles or more, you dramatically decrease the rate of follow-up for patients. So you've got huge swaths of this state that are almost totally inaccessible for the vast majority of patients for routine care in terms of eye care. So it doesn't make sense for us to set up this screening network from the retina clinics offices. Now, next slide, please. Maybe the slide back, one slide back. So then, well, where about the eye doctors? So eye doctors are ophthalmologists and optometrists. Well, there's far more optometrists than there are ophthalmologists. We're starting to get a little bit closer to the patients, but there you can probably see that there's still a significant number of regions where there's still actually lack of coverage of patients. So let's go to the next slide, please. So now you can get into, so this is the map of the primary care doctors in our state. And this is really getting much, much closer to where the patients really are. And that's really how we've directed our program, is to focus on primary care and building partnerships with them to do the screenings as part of their routine care and routine screening for patients who are diabetic. Next slide. Next slide, please. So when I took this over back in 2017, I think, there were a number of programmatic challenges. The cameras were quite bulky. I don't know if you've seen these, the Canon CR2s or the Topcons. The traditional cameras, the technology was difficult to use, very bulky, very difficult to move. If you had patients with some difficulty transferring or mobility issues, it was difficult to use those. The actual staff needed special training, and often that was difficult to come by, particularly these parts of the state that were 5 hours from Charlottesville. A lot of the cameras through the original screening network were donated secondhand cameras with no service agreement. So even minor issues like dust on a lens cap or dust on a lens could be showstoppers in some of these sites. We had lots of issues with staff turnover in some of our partnered clinics, which led to then inadequate training, these cycles of no training, trying to get training, and then sort of start and stop of the programs. Difficulty in terms of actually having some sort of a value add for the program in terms of community education, continuing education for the staff. And then, of course, sustainability and reimbursement issues. These cameras are very expensive traditionally, and some of the technology can be quite expensive. Okay, and a lot of the screening was not being reimbursed. Slide, please. Actually, I think it's one slide. No, actually, this is perfect. So just in the top, you have kind of what we were using in a lot of the different sites before. And then in the bottom, you have the Remidio fundus on the phone, which now our network, we use a variety of different technologies. We don't promote any one particular technology, but we've really seen how different technologies can benefit different programs much better. And we've really had a good positive experience, I think, with the Remidio system. You can really easily see how much smaller it is. This is, of course, built around a custom iPhone, so the staff was very familiar with that sort of a workflow, taking the photos, These are smart cameras that already have built-in upload to be able to send the images to the cloud and have them immediately available for our retina specialists to review. We do review in our program in via ophthalmology all of the images. And then there was actually something that was feasible for the sites to implement in terms of the reimbursement model to locally acquire the cameras. We really wanted to get out of the game of having to provide all the cameras. And because of the cost of the software, the service package, and the technology, it was feasible, unlike many other competitors, for a lot of the sites to actually buy the cameras themselves. Okay, next slide, please. So this is just getting at some very back of the envelope calculations, and to really dive into the nuts and bolts is going to take a lot longer. But just to give you an idea of some of the key back of the envelope calculations for a program, what you want to do is you want to look at the total cost, not just of the camera, but of all of the technology. So some of the cameras will require laptops, other things, software, service costs, etc. And then, of course, dividing by what the planned reimbursement is per patient. There's a variety of different codes for reimbursement that are possible. I will say that most of our sites have decided that 92250 is what they felt was appropriate, but you really need to make sure that there is a interpretation and report that's provided with every one of those reads. There's the new kid on the block is this 92229, which is for AI reads. That's a whole other ball of wax. Some of the sites have actually decided that they wanted the patients to contribute directly with some cash payments. But if you do this calculation, that'll give you an approximate number of patients that you need to screen to be able to at least break even for a program. And you really want to compare that against your payer mix of your diabetics and the number of patients in your diabetic patient registry to determine whether it's really feasible for this to be sustainable for your program for a practice on camera versus finding other solutions like leasing or working with a partner or have a grant funded camera or something like that. I'm not going to get into the weeds here about things like split billing versus negotiated payments. Most of our affiliated sites have negotiated payments, which is simpler for the non-UVA sites. But you have to, of course, think about in terms of how your capital budget is also set up within your clinic site. Next slide, please. We have a number of sites which, despite a lot of the challenges that really everybody's been facing with staff turnover and COVID and things like this, we have a number of sites that have really done an amazing job over the years of screening their patients. And one of the things I sort of talk about the 4 S's, staff, stuff, space, and I think it was service. And then there's another, which is support. And support is really the most important thing, I think. You really need a clinical champion in your site, and you need somebody to take ownership that this is what we're going to do. We're going to screen all the patients who are diabetic and make sure we're actually looking for preventable blindness in these patients. That's really important for program success. And then next slide. And this, I just want to leave on the note that so this is a picture of my uncle, Swagato Basumalak, who was a computer engineer in Silicon Valley. His daughter is a math prodigy, very capable person, but like a lot of us, didn't do a lot of preventative screening and had undiagnosed diabetes, which led to eventually his death, including diabetic retinopathy, congestive heart failure, and so on, at a very young age. And so this is one of my personal motivating factors for why we really want to move this away from just simply going from a treat as needed basis to really screening these patients for potentially life-threatening complications or vision-threatening complications. Thank you.
Arjun, thank you. It's clear to see the source of your passion behind your efforts, and I know that they're greatly appreciated. And thank you again for sharing your pearls of wisdom on setting up a diabetic retinopathy screening program. There's a lot that goes into it and a lot to consider. Before we go to the next presenter, I want to make sure that everyone knows you can enter your questions into the chat box and they will be reviewed by us. We'll try to answer them in our question and answer session at the end. And if we don't get to all the questions, we will be sending the question answers back out to you via email. So next, once we've Once a DR screening program has been started, and it's time to have great leadership to grow a program to scale. We're very fortunate to have an expert with us today that can share some of the best practices on doing that. Our next presenter is Denise Fisher. Denise is the Operations System Analyst for Ambulatory Optimization and Integration with Prisma Health. She oversees their diabetic retinopathy screening program. Prisma Health is the largest health system in South Carolina with over 600 primary care providers. So this is a significant organization. Denise, thank you so much for joining us today. What can you share with our audience on how they can improve and grow their DRS program?
I can tell you that the biggest thing is strategic project planning. I can't stress that enough. Carefully implemented project plan from the beginning to ongoing team care or team support. That is paramount. So I'd like to start out just good afternoon, everyone, and thank you so much for having me today. And I appreciate the kind introduction, Eric. I have been with the organization at Prisma Health for almost 10 years now, in my current role for about 6 years. I have managed our IRIS diabetic retinopathy program since its inception, and I am passionate about this work. I often tell folks that this reconnects me to patient care, and it's just very rewarding for me. The impact of saving sight is phenomenal, and I can't describe that when we do have our sight saves, and we'll talk a little more about that in a moment. I work with leadership and our team of end users to manage the overall project from, like I said, daily project planning to implementations to their daily support. Now, unfortunately, like many other organizations, we face some challenges with diabetic retinopathy screening compliance. That's why we brought in the great team over at IRIS, and through our partnership with those guys, we've been able to bring screenings to the patient in our family and internal medicine environments, as well as maternal fetal medicine and some OBGYN settings. That just helps improve that patient compliance for those patients in that population. The screening is super quick, it's convenient, and it's designed to be completed during the office visit with the use of natural dilation, and it allows the patient to simply sit in a dark room for just a very few minutes, and we can generally get those screenings. Now, since that initial implementation that I mentioned moments ago, that was about 5 years ago, and we have experienced a great amount of success and growth with our program. We began with only 4 cameras in a pilot program, and we have now expanded to 39 cameras in use in many practice locations across South Carolina. I personally am physically located in the upstate of South Carolina, but we have practices in the Midlands area of South Carolina and all the way down almost to the coast. We really are covering a vast area. Next slide, please. Prisma Health has implemented detailed clinical processes and workflows to manage our large-scale project. This includes detailed implementation project plans with time dependencies for our new practice sites, as well as ongoing communication with our teams. We do hold a bi-weekly implementation meeting with practice leadership in the weeks prior to a new camera going live in one of our practices. We find that this just results in a successful on-site training and support training and implementation. We support our teams through that process to be certain that they're completing the required steps for success. This includes being certain that our devices have been vetted through IT and clinical engineering. With the iPhone connected to the device, that does come with some security issues that we have had to really focus on, but we have that down to a very minimal approach now, and it's very quick. And then our team members have also completed their online training modules and set up their IRIS portal account. All of this enables them to capture the images and upload those images for grading. We do not use our own graders, so we do have to upload our images. Our organization, like I said, has so many areas throughout South Carolina. Without this strategic project management, it would be impossible to serve our patients in this area of diabetic care. It's our goal, and we impress upon our teams that this screening is just as vital of a part of their diabetic care as their hemoglobin A1C or their nephropathy screening. We place great emphasis on practice and team readiness during the implementation stage to ensure that our patients are getting the appropriate care. Now, you can go ahead to the next slide, please. As I mentioned a moment ago, we began our DRE program 5 years ago with a 4-camera pilot. I think our slides may be off. Can you go forward one? I'm not sure what's going on here. Go back one for me just for a second. Yeah. Here's where we are. Since implementing our program, we have completed over 17,000 screenings through our partnership with IRIS. Of that, over 2,000 of those patients have had some form of pathology identified. And I think most impactful is 900 have had a diagnosis of some type of severe sight-threatening disease. IRIS considers this and actually identifies this as a site save. And we here at Prisma Health monitor our site saves on a weekly basis to ensure that our providers have placed those referrals to go out and to our specialists to receive prompt treatment, as well as being certain that the patient has been notified. Now, most of these results are going to go out automatically through MyChart, but we do want to have a warm handoff for our patient, especially when there's a diagnosis of this nature involved. Now, if the referral by some chance, when we look at our site saves, has not been placed, we actually place and pin that referral for the original ordering provider, and then we send that referral to the provider to get that process expedited. We follow through with an email to the provider, indicating the importance of these being worked in a timely fashion. Now, of course, sometimes it happens on Monday and or the screening was on a Friday and the provider just hasn't had an opportunity, but this just provides another safety net to be certain that our patients are being taken care of. The program has resulted in an improved HEDIS score by more than 40%. As we all know, symptoms of diabetic retinopathy don't present until much later in the disease process. Dr. Rao did a really good job of explaining that. So while we're proud of our measurable improvement, it's even more exciting to realize how we're truly helping our patients. Next slide, please. So here are a few of the strategies that we have utilized to impact more of our patients. A few of our smaller sites share a camera on a 6-month rotating basis. Now, I'll be perfectly transparent here and tell you, I really wish that every one of our practices had their own camera. Rotating is not ideal, but I certainly don't recommend rotating a camera any more frequently than every 6 months. Ideally, again, most of our practices will have a camera, but let's be real, sometimes that's just not always feasible. Since most of our patients will visit their provider during a 6-month period, this does allow us to reach the majority of our patients. If a practice just doesn't have the volume to warrant a camera year-round, or when budget constraints might prohibit the purchase of additional equipment. A structured plan with reminders to rotate the camera on a timely basis are critical for this to be successful, and I do manage those rotations as well. Additionally, we hold monthly virtual meetings with all of our teams and IRIS to celebrate wins and collaborate to resolve challenges. We do include practice leadership. Physician leadership is always optional, and our end users, if available, I like to plug in that if available, because our staffing right now is just so lean. I'm certain that everyone has experienced that. But we also include operational leadership. Each practice is expected to be represented on this monthly call. We do provide an educational topic each month or address a challenge we are seeing more widespread on each month's call. As well, we briefly check in on each practice on this call just to ensure they have the needed resources to be successful as they serve our patients. I will tell you that, a lot of folks may say, why, that's a lot of touch point, that's a lot of communication. It is, but I'll tell you, our greatest wins have come out of this call because of the collaborative efforts of our team members. So it's been critical during these times of lean staffing. Yes, it's a meeting, but we have been no exception to these lean staffing levels here at Prisma Health. But I have been amazed at the strategies that our end users have come up with to be able to combat that and still get the screenings. But again, here at Prisma Health, we're treating it just like a hemoglobin A1C. So the fact that we're short-staffed, we really try not to let that come into play with getting this. We value our end users very much, and they are truly our experts. So we want to be certain that we offer them some ongoing communication opportunities. As well, in partnership with IRIS, we hold continual in-person activities. So that first thing I talked about, that was a virtual call that we do once a month. So including these continual in-person activities are include an IRIS trainer and also a super user from Prisma Health. These in-person clinic visits, they're held annually. So we're going to touch base in every practice annually. And we hold in-person biannual super user meetings. So we have another super user meeting twice a year that's in person. And we rotate that between our Columbia market or Midlands market and our upstate market. That's been very successful. It gives each person some ownership, and we just really collaborate and celebrate during those times. One of the biggest things that we have done for success in our program is we are maximizing our use of Epic for patient identification. For example, we actually had a column added to the multi-provider schedule so that the clinical team can see immediately which patients are due for their screening. They get that if anyone here is familiar with Epic, you get a light on there. It just lights it up red or puts a little clock. If it's due soon, it tells you immediately if the patient is due for their retinopathy screening. This allows the team to be ready to perform the screening. Now, we typically encourage our teams to get the screening towards the end of the office visit. We don't want to impede our provider schedules. However, with this information right there front and center and the providers running just a few minutes behind, the screening can actually be completed before the patient is seen. Some of our users who are just like super quick, they do this frequently and it works out great. Doesn't take any more time during the office visit. Epic obviously allows us to run registries and reports to determine which of our patients are due for screening. We've had a few of our practices that if their staffing allows, or they have their provider, they're going to be low providers on a specific day, and they have an extra medical assistant or nurse or whoever that can perform the screenings, they'll actually do a screening clinic, a diabetic retinopathy clinic, to bring patients in for a quick nurse visit to get the screening. Now, I will say that's more of an exception, not a norm. Most of our screenings are done while the patient is in the office for their regular follow-up visit. Here at Prisma Health, next slide. We very much appreciate our, I think I have one more slide. I think it's just my ending slide. We really appreciate our partnership with IRIS and Remidio. And again, I really do appreciate you guys having me today.
Denise, thank you again. Thanks for sharing some very practical best practices from Prisma Health. I think these tools can really help improve patient care and help those clinical quality measures. So thank you again.
I just
wanted to remind everyone, continue to put your questions into the chat box. We've got some great questions. We're going to get to those at the very end. We have one more final presentation before the Q&A session by Louis Morrow. Louis is the Vice President of Sales for Intelligent Retinal Imaging Systems, or IRIS as we refer to it. I've had the opportunity to partner with Louis on DA screening projects across the US. With his industry knowledge, his leadership, and his focus on patient outcomes and customer success, you won't find a much better resource when you're building your own DR screening program. So Louis, tell us a little bit about the approach IRIS has towards building and maintaining successful DR screening programs.
Yeah, happy to, Eric, and thanks again for the team here at Remidio for including me in the conversation. So really, what drives every aspect of our approach is the fact that our group here at IRIS is solely mission focused. You heard the physicians earlier speak about how diabetic retinopathy is the leading cause of blindness, and our mission then is to end preventable blindness, and that's certainly a big part of the day-to-day work that my colleagues and I are focused on here at IRIS. Because we are mission-driven and mission-focused, we've implemented really a programmatic approach, and you've heard Denise speak about that partnership that we truly value with the team over at Prisma. So let me walk you through a little bit of how we approach specific clients. And this will apply to not only what we put in place over at Prisma, but really this is our standard approach. And really, it's a very simple 5-step process. Where it begins is, I'd like for the folks to think about really everything beyond the camera, right? We've heard from a number of folks today about how effective the Remidio device can be, and that's an important part of these types of programs is a cost-effective, lightweight, portable, easy to use, and effective device. Iris really manages everything else beyond the camera. We've relied on our partner like Remidio, and we work with other manufacturers as well on the hardware piece, and then we manage the rest of the elements of that program. So for example, in step number 1, you heard Dr. Arjun mention that one of his challenges was that ongoing training that's really, that support that periodically can be missing. Well, Iris owns that element. We have a staff of trainers that work with people like Denise and her team on a very regular basis to implement not only the device, but the overall workflow. So that's really think of that as the beginning of step 1. These folks are capturing images in any environment. You heard that really we can do this in a traditional brick and mortar primary care environment, but also in patients' homes, in retail settings, in lab settings, in community-based events, really wherever a diabetic is. The technology exists today, both with the hardware and as well as the Iris platform, that we can do these exams anywhere. Once those images are captured, a click of the button on most devices uploads those images to our cloud-based platform. We find, and Denise mentioned it, the exam in that environment can be very quick and easy. Non-mydriatic, so we're very, very typically not dilating patients here. Once those images are exported, that's when they hit our platform, and a series of proprietary algorithm-based technologies are applied to every image that we ingest. And these are enhancement algorithms that take those original images and make them significantly more clear. It strips away some of the oranges and the reds that you would typically find in a fundus photograph. And what that allows is for the most impactful interpretation by our grading physicians, which then brings us to step number 4. We manage and maintain our own reading center. Today, we have a number of more than 100 licensed and board certified, board eligible ophthalmologists and retina specialists that are not employed by Iris, but all on a 1099 basis that are performing these interpretation services. Denise mentioned that they rely on our grading physicians to provide that interpretation. So what they are doing is they are looking for markers, signs, and symptoms of diabetic retinopathy and macular edema that they can diagnose. But because we have that human element from an interpretation standpoint, there's also a whole host of additional ophthalmologic conditions that can be identified or suspected through that human review. Things like cataracts, glaucoma, macular degeneration, hypertensive retinopathy. There's a number of other things that can be identified through the interpretation of this fundus photograph. The last step is the platform, the Iris platform, automatically compiles a result and sends that back to the originating ordering provider. And in most cases, as is the example that Denise shared with you about Prisma, we have this entire process fully interfaced with our client's EMR system. She spoke about Epic there at Prisma, but we've interfaced with all of the major HL7-based EMR platforms, which really maximizes the efficiency of that workflow. In particular, this Remidio device can accept an order from that inbound interface from the EMR. So again, there's no manual data entry. We are just selecting and activating a patient order, capturing images, clicking a button that says export, and then we do the rest here at Iris. So those 5 simple steps is our approach, really. There's a very quick turnaround, typically next business day, of that human interpreted result. And we're really proud of the fact that we've focused on the full comprehensive solution here. The camera is an important part of it. Absolutely. It's got to fit into this workflow. But there's other elements too that we over time have developed and simplified into this easy 5-step process. So why don't we move forward here and talk about some of the benefits on the next slide of why folks do this. This is part of the reason why Denise and her team at Prisma do what they do and why they chose Iris. And that's because of this comprehensive approach that we have, this true end-to-end solution. What we're not is we're not a transaction-based organization. We're not motivated to sell hardware only. It is truly a comprehensive ongoing partnership. And you see that here on the second bullet. Denise mentioned all of the ongoing support that we do: site visits, rounding, refresher trainings, annual business reviews. Those are all standard elements of the Iris partnership that folks like Denise and her team over at Prisma have experienced. I also mentioned the significant benefit of that EMR integration, which works to minimize the impact in the clinic environment. Denise mentioned it. Folks are strained already. Staffing is an issue, and as easy and as limited that we can make this as possible, that's a good thing for all folks involved. And certainly the addition of that bidirectional interface with Epic certainly serves to do that. We also, in addition to those support tools, offer a number of other tools, such as an analytics dashboard that I know Denise and her team look at very regularly. She mentioned Iris Saves. That's how we track those types of metrics, through a real-time, constantly updated analytics platform through our application that our clients have ongoing access to. We even provide an ability to do some of the similar back-of-the-envelope financial analyses that Dr. Arjun spoke about earlier, where we're really looking at what's the simple ROI when it comes to the upfront capital investment and the ongoing expense, as compared to the potential financial benefits, not only from a fee-for-service standpoint, but the bigger impacts when it comes to HEDIS performance, value-based care incentives, risk adjustment benefits if you're into those risk-based contracts. Overall, we are very, very proud of the impact that we've had. Earlier this year, Iris, through all of our partnerships, we conducted our 1 millionth diabetic eye exam. That's a real impact that we've been able to have with our client base. And of those roughly 1 million exams, about a third of them come back with some level of pathology, whether it's a true diagnosis or a suspected condition. And of course, that varies depending on the demographic base, the part of the country that you're in. But overall, a third of all exams come back with some type of pathology, which tells you the importance to this patient base of having access to this exam. And over a lifetime, we look at this number internally very, very regularly. We've been able to identify sight-threatening pathology in 130,000 diabetic patients. Then, because of this platform, then that referral takes place. Presumably that patient gets to the right level of care with the right sense of urgency, so that we can at least begin the process of treating that patient in the proper environment. So overall, we are extremely proud of the partnerships that we have had with our folks like Prisma. And I'd love to show you a little bit about what more of these financial impacts can be. We've certainly talked about the patient benefits here. First and foremost, more important than anything else that we've discussed here today, is by offering this at the point of care, we increase the chances of early detection and ultimately work towards preserving the vision of that patient. The clear and number one benefit of programs like Prisma, programs like UVA, programs like Iris, that is the number one driving factor. But there's other benefits as well here, secondary to the patient benefit. Certainly, Denise spoke about their improvements in their HEDIS performance, improving that performance by 40%. That's made possible because when our clients implement the Iris solution, they now have control of this historically really challenging diabetic eye exam measure, whereas the previous methodology, where patients have been asked to go to see their eye care provider, there's not a lot of control, and hence there are a lot of places where that can break down. This also in primary care serves to really drive a deeper conversation on behavior change. If I'm a diabetic and I'm told that I might potentially lose my eyesight unless I make some changes to my lifestyle, that's going to make my ears perk up and certainly be motivating to make some changes. We've talked about the health system benefits, but there's also if your health system, like University of Virginia, has internal ophthalmology, then there are potentially some benefits in terms of minimizing leakage, which we hear from other health systems with employed ophthalmology. That can be a driving factor to implement. And we also know that payers are very motivated and driven to close these care gaps because of their ability to improve their own star performance, particularly in the Medicare Advantage world. But also we know the bottom line is treatment of retina disease is, if it's caught too late, can be a very expensive proposition with the use of the anti-VEGF injectables that are out there today. And if we can catch it sooner, then we can avoid those more expensive therapies and allow for the equally effective generic medicines to be implemented to manage early stage disease. So those are the benefits of working with us. We're proud of our relationship with Denise and the Prisma team. We're also very happy to be working here with Eric and his team at Remidio. We work with other camera manufacturers as well, but in this case, we're really pleased with the results.
Yeah, thank you, Louis. You make it all sound so easy, and I think that's great. I mean, that's really is the key here, is to try to make it not just easy on the patient by getting closer to where they are, but make it easier on the clinics as they get ready to set these things up. So now we're getting ready for the question and answer. Please continue to put your questions into the chat box. We've got some great ones that we're going to answer here. But before we do that, we do have one more poll question for you. If you could put that up on the screen. Who benefits from diabetic retinopathy screening? We'll give you a few seconds to answer. It's sort of live post. It'll live post the results as we go. So let's see. We've had several questions, and as the poll comes up, I'm just going to go through and sort of pick some of these out. And again, please continue to put them in. We will continue to answer them even after the webinar. So here, this first one, I think I'm going to give to Denise, if it's okay. U.S. healthcare systems pay a lot of emphasis on quality metrics. Can you elaborate a little bit more on HEDIS measures and what improving HEDIS measures means to, a primary care provider?
Absolutely. I'll be honest with you. I think it's been said over and over here today that the patient impact is huge. Everyone here focused on that, and it's obviously the most important focal point. I believe that completing the exams, I know completing the exams for our diabetic patients is a current HEDIS measure. Here at Prisma Health, we consider the DR screening a standard of care, along with nephropathy screening and their hemoglobin A1C control. I think it's pretty well known that meeting these quality metrics can result in financial incentives for the health systems, although individual incentives to providers can vary among organizations and their decision to incentivize the providers or not.
Excellent, thank you. Let's see, this next one, I'm going to ask both Arjun and Louis to maybe answer this. And Arjun, if you want to go first, but both Iris and UVA offer both handheld and desktop style cameras. What are the customer considerations in selecting the right device for them? And to add on to that, I would add, how big of a consideration is connectivity and integration? So Arjun, why don't you answer first, and then Louis can maybe take that one on.
Sure. Thanks, Eric. So there's a variety of different technologies that have been used in our programs. At this point, pretty much all of the sites, whether they're being Remidio or other competitors' cameras, they're all using some sort of a tabletop type setup. That being said, the Remidio camera is a sort of a transformer, so it can go into a handheld mode as well as being in a tabletop setup. with an adapter. And this is one of those things to where the usability ends up becoming really key in looking at the specific patient population, because we have a lot of sites where some of the patients may have difficulties transferring, they're wheelchair bound, some of them are on stretchers. There's a variety of different reasons why the tabletop may not work in certain patients, but tabletop is just, I would say, just for most patients is a little bit easier to get a good quality capture. But handheld is one of those things to where you're able to sort of, come to the patient a little bit more easily. And so for some of those edge cases, it's nice to be able to have that as well. But there's a trade-off, I think, in terms of some of the usability of the camera. I hope that's useful.
Yeah, I would agree with that 100%. In fact, we use that term all the time, trade-off, right? We have to consider what are the most important factors with our clients on how they base the decision-making criteria. And we can list a number of them, right? Certainly one is ease of use that Dr. Arjun just spoke about. Real estate, how much room do you have in the space? Can you accommodate the larger tabletop? What's your capital budget? The tabletops, while certainly a little bit more automated and easier to use, they are 2 and potentially 3 times more expensive. So we've got to consider that as well. Then there's the technology that's available on a handheld versus a tabletop. Sometimes there's immediate feedback technology that gives you, sort of a thumbs up or thumbs down on whether or not the image potentially would be gradable. So we take in all of those factors that we learn from our clients and guide them through that decision-making process and transparently help them understand what that trade-off actually is. And in the end of that discussion, then we arrive at what makes the most sense. And as you heard Denise say, Prisma ultimately landed on these handheld devices. She spoke about rotations, and while not ideal, that's potentially part of those factors. And we also look at, we haven't really spoken about this yet very much, but we look at success rate or gradability, which really directly relates to ease of use of the device. And with the proprietary enhancement technology combined with the high quality devices that we partner with, Iris has been able to achieve a very high industry best gradability of in the low to mid 90s when all these other factors are considered. So that's what I would say, Eric, is what we hear from clients on how they make that decision.
Thank you. I have this one, and this question came in is, does your team have I'm going to send this one to Denise, I think is appropriate for, do you have a team of your own that follows up telephonically and directly with the patients to ensure that they're proceeding to that next level of management of their care? I guess that's back to sort of the follow-up. How do you do that?
Absolutely. Understand. No, we do not have a specific team dedicated to that. That goes back to the practice level to follow up on their patients and their referrals. It's not really as tedious as it sounds. If you work the referral through your work queues, it flows for itself.
Gotcha. I have another question here. I'm going to give this one to Dr. Divya. A lot is said about diabetes and diabetic and how it's a chronic disease. I guess, what is the hope for a patient with diabetic retinopathy?
Thanks for a great question, Eric. I think all of us eventually rely on hope, right? And I think definitely for diabetic retinopathy, there is hope. Therapeutics have really advanced, not just for diabetes, but also diabetic retinopathy and management of and treatment of things like macular edema associated with diabetic retinopathy. We have number of new agents, anti-VEGF agents, which have come in, reduced dosing schedules, better patient visual acuity outcomes, advancement in surgical techniques have also resulted in better patient outcomes. But the key is to detect and administer this treatment in a timely manner. And definitely there is good news and hope in being able to prevent almost all of the blindness associated with it.
Yeah. Thank you. In my experience, that's the number one motivator for staff in primary care offices, to know that if they identify it, there's something that can be done that actually halts the progress. I think that's very important to sort of cover. We have another question here. It was brought up briefly, but I'm going to put this one to Dr. Divya and Dr. Arjun. In your opinion, what's your opinion on the use of artificial intelligence in diabetic retinopathy screening?
So I definitely think there is a role for AI in diabetic retinopathy screening, either as a clinical decision support tool or an autonomous solution to improve either workflow efficiency, turnaround time in terms of reports, as well as improving patient compliance, I think, in the next steps in management. We've made some headway here, and there are a few AI solutions out there for diabetic retinopathy screening that are regulatory approved and also are reimbursable. But I think what's important moving forward from a patient outcome perspective and public health perspective is we need to look at not just screening for one condition, an AI that looks at only one condition, right, like diabetic retinopathy. Because at the end of the day, this high-risk group has several other pathologies as well, as Lewis has rightly pointed out, and so did Denise. There are almost 30% of the patients that they have seen with other pathologies. So moving forward, we really need to look at an AI solution that looks at multiple pathologies and not just focused on diabetic retinopathy. I'm sure even Dr. Arjun, being a glaucoma specialist, would say that, diabetes is a risk factor for glaucoma, and you can't have an AI solution that just looks at diabetic retinopathy. I think the current limitation is that.
Yeah, that's very excellently said. I mean, so at UVA, and we have an AI concordance study that's planned to look at how the artificial reads correlate with our human reads. We do human, we have retina specialists who look at all of our images in our program and read them. As Dr. Rao mentioned, the top non-diabetic retinopathy pathology diagnosis that's found in all of it. So the number two condition that's found in all these images is my field, glaucoma. So glaucoma suspect is sort of the number one non-diabetic pathology. And there's a number of other things that we pick up on as well: vein occlusions, a number of other things, tumors, other things. So there is now there are two and now three FDA registered autonomous tools that I mean, and there's trade-offs here. One of the amazing trade-offs to me has been that you close that gap of having to wait for a human read, which is, at the patient level, that's a real barrier. These patients sometimes will leave. Are they actually going to come in for follow-up? You've got this sort of sometimes a limited window of time in which you can get that patient in, like, okay, you've got a positive read. You go to see eye doctor X to get your in-person exam to see what needs to be done about this, right? So that can solve that problem. But the other problem, as Dr. Rao mentioned, is that you're only looking at diabetic retinopathy screening. That's the way the regulatory environment is in this country, is that it's sort of disease specific. And so in this country, that's, again, it's only going to look for diabetic retinopathy. If there's anything else, who knows? And so that's I think that's an important fact that we need to take into account. And there's the cost considerations. The cost is actually, it's an open question as to how so the tools that are available in the market, the autonomous solutions, and the very limited number of cameras that have been approved for this purpose in the software, it's pretty substantial. And so the question is, how feasible is it to really deploy at scale? And we don't know yet.
Thank you, Arjun. We're running out of our time allotted here, so I have just one more quick question, and it's I'm going to take this one. It's I'll put this over to Lewis to answer, and I think this question has come up with you in some of the accounts, but with technology changing so fast and new updates always coming, how many years can one expect a retinal camera to be functional before it needs to be replaced. And, issues like end of life come into it, also HIPAA compliance because of the software being updatable and so forth. Louis, do you have a quick response on that before we wrap up?
Yeah, happy to address that. And unfortunately, I can't give a definitive answer because it's really going to be driven by the camera style that's chosen. I think it's intuitive that a non-mobile, larger tabletop is probably going to be a little less susceptible to the normal wear and tear that you would see in a lightweight, mobile, handheld device, which might be a little bit more prone to more routine damage, right? Just because of the nature of that environment. So I would say, generally speaking, the tabletops probably have a little bit longer lifespan. But here again, we go back to what we talked about earlier, which was the trade-off and the technology adaptability and the advancement in the technology and the hardware piece. We've certainly seen that accelerate the past few years with the AI element that the ophthalmologists have just spoken about. So I can tell you that in terms of our experience, the handheld that we have deployed, including the Remidio device, have been pretty durable. Occasionally, there's expected damage and repair that needs to be worked, and the Remidio team has proven to be very helpful when it comes to those types of support issues.
Thank you. And if anybody has a question about that afterward, I'd be more than happy to share, the personal experience or what we've experienced with Remidio. We're now on our 10th iteration of this device. All of them are upgradable to today's technology, today's software. That's the wonderful thing about using the iPhone technology. You just simply take the iPhone off and put on a new custom iPhone, and you're right back into the latest technology. So, but thank you everyone for your time. I really want to thank the panel today for their presentations. I believe I speak for all of us. Please reach out to us anytime if you have any questions about your diabetic retinopathy screening program. I think we're all here to help. Thank you again to all the participants for attending today. Any questions that we've gotten that we didn't get today, we will follow up with emails and send them out to you. And we will send out a link to today's recording for future reference. So please have a great rest of the day, and thank you for attending.
Thank you, Dr. Arjun.
Thank you so much, everyone. Bye.
Thank you, Denise. Thank you, Louis.